Dear members, I'd like to introduce our speaker, Melanie Boyce. Melanie has a bachelor's degree in applied science, physiotherapy, and master's also in physiotherapy. She's a senior physiotherapist at Westmead Hospital, Sydney, where she specialises in treating patients with complex neurological conditions, including Parkinson's disease and dystonia. Melanie completed a master's in applied science in 2012 at the University of Sydney, conducting a clinical trial investigating the role of physiotherapy in the treatment of cervical dystonia. Melanie is currently enrolled in her PhD through the University of Technology, Sydney, exploring the impact of living with cervical dystonia. Today, Melanie is going to present the findings in a recent dystonia research. So I'll hand you over to Mel.
Thank you, Lorraine, and thank you, Kerry, for giving me the opportunity to speak today. Okay, so thank you. Yes, today I'm going to be talking about the results from my first study, which looked at walking, balance and arm function in people with cervical dystonia. But before I do, I just thought that I would introduce myself a little bit as well, but although you've basically covered it, Lorraine, I think mostly. So I've been working at Westmead Hospital since 1998, specialising in neurophysio. I started working with people with cervical dystonia in 2005 and then started researching from a physio side of things in 2006. So I've been doing this for quite a while, and it's been really an interesting twist or turn to my career, which I've really enjoyed. And there aren't really very many of us researching cervical dystonia in physio at the moment, as I'm sure you're all aware. But the positive thing about it is that there has been a whole lot more people take up this area of research since I started in 2005. So I think the future is looking quite bright for research around physio and cervical dystonia, just because there's many more people in the world interested and looking at different ways to help people with cervical dystonia. So today I'm going to talk to you a little bit about my first study in the PhD I'm doing at the moment, and the PhD is entitled The Impact of Living with Cervical Dystonia, and at the end I'll just talk a little bit about how this research fits in with the rest of the PhD. Before I start, though, I'd like to acknowledge the wonderful supervisors that I have at UTS, Ariane Verhagen, Alana McCambridge, Lindley Bradnam and Colleen Canning, and also the neurologists at Westmead, Dr. Neil Mahant, Florence Chang and Victor Fung. I'm sure a lot of you will know these people and may have participated in studies or seen them before, and they're wonderful helps to me when I'm doing all of this research and treating the wonderful patients with cervical dystonia. I'd also like to briefly mention I've had 2 scholarships from Westmead Charitable Trust and the Westmead Medical Research Foundation, and that's been really vital in keeping me going with this research and helping me to get to the end, which hopefully will be fairly soon. Well, in the next few years. The last group of people I love to acknowledge are the wonderful people who participate in my studies. I really enjoy meeting new people with cervical dystonia, and most of you have done something for me in terms of a research participation, and that's really excellent, and I thank you very much for helping out. Okay, so most of you probably know what cervical dystonia is, but just in case there's a few of you who don't, it's a neurological condition which just affects the neck, which is why it's called isolated and focal, so just the neck and the shoulder, upper arm area. It causes the neck to turn away from the normal position, as in the picture here, and your neck can turn in any direction. At the moment, the current thinking is that the condition is what we call a network disorder. So that means there are many parts of the brain that are causing the dystonia, so causing the neck to turn, and they all work together to cause this dystonia. So the parts of the brain we know of at the moment, and there may be still more, are the cerebral cortex, the basal ganglia and the cerebellum. Now, many of these areas of the brain also have a role in coordination of movement. So that is why we were starting to think that perhaps people with cervical dystonia might also have problems with their walking and their balance, just because those activities require a lot of coordination of movement. So a lot of different areas of the body have to coordinate in order for you to balance and to walk effectively. So a little bit of background. So this is all work done by other people prior to my PhD. What we know at the moment from people with cervical dystonia and their walking is that people with cervical dystonia walk slower than healthy people of the same age. And they also have, they show slower times on the timed up and go, which is a walking assessment where you have to stand up, walk 3 meters, turn around a cone and walk back and sit down. So it's a bit of a coordination balance. It assesses coordination, balance and walking, a bit of a whole, looking at a bit of everything with movement coordination. So people with cervical dystonia are slower at that than healthy people of the same age. And also people with cervical dystonia have more fear of falling. So they report that they're more scared or more frightened of falling over than healthy people the same age. And as well as this reported fear of falling, a few years ago we did a survey, and not only did people report they were afraid of falling, but 45% of people with cervical dystonia reported that they had had a fall, so they'd actually hit the ground in the previous 6 months. So when this background information came together, we decided that maybe this was something we needed to look into. Is this actually a problem? You know, are people falling over? Is their balance a problem? Because from a physio point of view, particularly a neurophysio point of view, we certainly can do exercises and have strategies that might be able to help that. So that led us to the study, which has taken us a while to do, but has finally been published just a month or so, 6 weeks ago. So it's called a cross-sectional study of walking, balance and upper limb assessment scales in people with cervical dystonia. So I'm going to go through what we did. So the aim really was to look broadly at balance, walking and upper limb or arm function in people with cervical dystonia. And I wanted to use common clinical assessment scales. So that means things that normal physios, every physio in the world would know and understand and be able to reproduce. So that if we did find that there was something there that people needed to investigate and treat, then there wouldn't need to be any specific knowledge or, you know, training or anything. Any physio across the world would be able to assess that and be able to treat someone with cervical dystonia. It's quite important to me that, well, my particular interest is doing things that people in the clinic can reproduce, so that rather than doing lab-based studies, so that, you know, whatever I produce can help people on the ground when they're faced with a person with cervical dystonia. So they have a bit more knowledge and understanding of what they should be how they can help. The second thing we wanted to look at was to see if dystonia severity was correlated with performance on these assessment tasks. So basically, if your dystonia is worse, is your balance worse? Or if your dystonia is worse, is your walking not as good? So they were the two main aims. We asked for people to participate who were adults with cervical dystonia who could walk without a walking aid. We wanted them to have no other conditions that affected their walking or their balance, just so that we knew it was just the cervical dystonia we were assessing. People could be on Botox, that was fine. We just wanted to assess them within 7 days of the injection, so that the effect of the injection was at its least. And in reality, everyone who was on Botox was assessed within 1 day of their injection, so that usually the same day, and at the worst case scenario, it was the day before or after. We actually got 2 physios to score the assessments, and we also looked later at whether the physios scored them reliably in the same way, which it turns out that 2 physios did. So this is the baseline information we took, which is just your basic demographic information, age, gender, diagnosis, blah, blah, blah. The twister, the TWSTRS, has a very long name, and it's actually the severity assessment we do for cervical dystonia. So it looks at how bad the dystonia is, how much pain people have with dystonia, and how much disability they have with dystonia. And the MOCA is a cognitive assessment, which again was just a baseline assessment. Now, these are the physio-specific assessments and the ones we were really interested in. There were lots, so I was really thankful to the people who participated. Hopefully, maybe some of them are watching today, because it took quite a long time to do all of these assessments, and they gave up you know, a good few hours of their time to help me out. So thank you to anyone who did participate. So the first three, the three in red, are questionnaires that were completed by the person on their own. So the first one, the ABC, is looking at how confident a person is in their balance, so how confident they feel that their balance is okay. The second one, the FESI, the Falls Self-Efficacy Scale, is a scale that looks at fear of falling, so how frightened people are of falling over. The third questionnaire was the IPEC, Incidental and Planned Exercise Questionnaire, and that was just a way for us to try and quantify how much exercise a person is doing in a normal week. And we covered everything from doing the housework, like, you know, standing up, doing the ironing or cooking the dinner, to, you know, going for a run or playing tennis. Or so it's every amount of exercise you do, from minimal stuff at home to the more vigorous activities you might do out of the house. Okay, so then we did 5 walking and balance assessments. So the FGA, Functional Gait Assessment, is a walking assessment. The Mini Best is a balance assessment. And then the 5 by Sit to Stand is the time it takes you to stand up 5 times. The 4 square step test is the time it takes you to step around in a square and then back the same way. So you step to the right, backwards, to the left and forwards, and then reverse the process. And the figure of 8 test is the time it takes for you to walk in a figure of 8, so around 2 cones. But wait, there's still more. So people were getting tired, but they hung in there and they kept going for the last few assessments. The last couple of assessments are upper limb assessments. So I have a picture there of the box and block test. It is a test of the upper arm, so how the upper arm is moving. So what you have to do is move the blocks from one side of the box to the other, and you have a minute, and we time how many blocks you can move as fast as you can from one side of the box to the other. So it actually is measuring how quickly you can move your shoulder. And then so that we would cover the hand, we did a very quick hand test, which is a coin rotation test. So people were given a 10-cent piece and they had to twist it in their fingers as many times as they can in 15 seconds or 10 seconds, I think it was. The assessment of cerebellar signs was just a screening assessment, really, to see whether people had signs that their cerebellar was not working properly, and everyone had basically no cerebellar signs, so that was good. And the last thing we asked people to do was to keep a falls diary for the following 6 months. So each month I would contact people, usually via email, and just check if they'd had any falls in the preceding month, and if they had fallen over, then I would give them a call and just find out what happened. You know, were they injured? Did they need to go to the doctor? Were they okay? That sort of stuff. Okay, so that's the assessment. It took about 2 hours. People were really, really patient, which is great. So this is a very busy table, and I'm not going to go through every number because obviously that would be annoying, but I will highlight a few important things, and then I have a summary at the end of what it sort of all means. So we had 22 people complete the study, which is pretty good for a study just run in one city in a small country like Australia, because there aren't that many people with cervical dystonia here. So that was not a bad number. Obviously, the more the better, but it's not a bad number for the situation we found ourselves in. Interestingly, we had 14 people who were men, which was 64%, which is actually the opposite from what the research shows. In general, women are more commonly affected with cervical dystonia than men, but just for us, I don't know why, we managed to find all the men in Sydney. The average age of our participants was 61 and a half, but we did have some younger people, 34, and some older people up to age 80. So we had a broad range, but the average age was 61. The majority of people, 68%, were on Botox and regular Botox, so not just a one-off. And then in terms of types of dystonia, most people had a combination. So most people had a torticollis, so their head tilted and twisted, or tilted backwards and forwards and twisted, so had a combination of dystonia. Okay, most people had dystonia for around, well, the average time was 11 years. And then if we look at the twister score, 32.5, that's the average twister score for everyone. And that falls into the mild to moderate category. Now, we did have some people, 5 is basically nothing and 71 is quite severe. So we did have some people at either ends of the spectrum, but on average, the group were in the mild to moderate category. And then everyone scored normal on the cognitive assessment, which is good. So these are the assessment, the physio assessments we did. So again, a lot of numbers, and I'll explain them slowly, but not go through everyone. So I'll just tell you the ones that are really important. I've just lost my cursor. There it is. Okay, so the ABC, this was the Balance Confidence Questionnaire. Now, our group, this is the average of our group, this first number, 80. And then over here, we have the average of other groups that are from research that's already published. And this is the age of the other groups on this column here, okay? So our group scored 80 on the ABC on average. And that's basically the same as these other papers that are published with healthy people, not without cervical dystonia. However, the healthy people were 10 years older than our group. So our group scored, and actually it's pretty much the same for the fear of falling questionnaire. Our group scored 27, and the published data says the healthy people scored 29, which is pretty close, but they were in their 80s. So in terms of our fear of falling and worried about falling over for people with cervical dystonia, they're scoring about the same as people 10 to 20 years older. Okay, so that indicates there's a slight problem there. They're only in their early 60s and they're worried about falling over like someone in their 70s or 80s. Okay, the other questionnaire was really interesting too. So this is the exercise questionnaire, how many hours a week someone exercised, and our group reported 23.6 on average, and that is quite a bit less. This is reported data from quite a large study actually in healthy older people. So the average age for this group was much older than ours, so late 70s, and yet they were doing more exercise than our group. Okay. I'm going to talk a little bit about why some of these things might be a bit further on, but this is just to highlight the things that came up quite different. Okay. Now, these next couple of tests are the walking and balance tests. So the mini best, 24 was our average score, which is about the same as people the same age. Similar with the functional gait assessment, the 5-time sit to stand, and the 4-square step test. All of those walking tests are pretty similar to people of the same age. So we don't need to worry too much about walking and balance. The actual scores of when people were doing the physical tests came out about the same as people their own age. The figure of 8 walking test was actually a little bit better than people about the same age or a bit older. So that was interesting too. So turning directions, the dystonia people were actually a little bit better. So far, walking and balance appears not to really be affected. However, people are worried about falling over more than they probably should be, and their level of exercise is a bit less than older people the same age or older. So looking at the very last couple of things, the upper limb assessments, this one was the most interesting, I think. The box and block test, which is the test where you move the blocks from one side to the other, and it's testing your shoulder movement. Our group scored 55 and 56 for the left and the right hand. But for people exactly the same age, 60 to 64, they're scoring a whole lot more in the published data, so in the 70s. So really, people with dystonia, this is, I think, was our biggest finding. Their shoulder movement is much, much slower than people of the same age. But weirdly, or maybe not weirdly, their finger movement, so turning the coin, so actually doing a finger movement, was basically exactly the same as someone the same age. So it looks like the shoulder is impacted by cervical dystonia, but the hand isn't. So you can still move your hand any old way. Shoulder moves slower. The ataxia scale came out like at 1, which is just negligible, so no issue there. No one really showed cerebellar signs. And falls, we had 5 people who fell out of the 22, and 2 people had 2 falls, so there were 7 falls in total. Now, I did investigate why these people fell, and majority of them, it was trip or a slip or something like that. The average age of the people who fell was 69, and they were all women. Unfortunately, the risk of falling for women is higher than men, and it goes up the older that you get. So we think that we can't really draw any firm conclusions on that number of falls, or whether or not dystonia has any effect on falls, because it's very possible that they were just coincidences, or be due to the fact that it's the older people in our group who fell rather than the younger people. Okay, so I've gone through the horrible table. I'll just summarize it now in a few words, so that if anyone wants to look at this later, you can read the words rather than look at the table. Okay, so basically our group had a moderate dystonia, so mild to moderate dystonia of about 10 years duration. Most people were men, and their average age was 61, and most people were having Botox as well. So the findings, we found that our group were less active than people in their 70s, and that they had a fear of falling and were worried about falling over, that was similar to people in their 70s and 80s. However, we have cutoff scores for all of these scales. So basically we can look at the scores that our people reported, and then look at cutoff scores for risk of falling, and none of our people fell into the risk of falling. So basically what happens is, if you score, say, over a certain amount on the ABC, that means you're at a very high risk of falling over. So even though our group were worried about falling over, they weren't actually technically at risk of falling, and it looked as though their balance and walking was pretty much normal. Okay, so the rest of the findings, just to summarize, the upper arm movement was slower than people of the same age. However, the hand movements were unaffected. So the moving your fingers was fine, but moving your shoulder was slower. And the assessments of walking and balance were very similar to healthy people of a similar age. And in fact, walking around in a figure 8, the group of people with cervical dystonia were much better. Okay. The other important thing to find was that there was absolutely no correlation between dystonia severity or the level of exercise and the results on the physical tests. So as people had worse dystonia, they didn't necessarily record worse scores on the physical tests. And similarly with the levels of exercise, if there was someone who really didn't exercise hardly at all, they weren't scoring any worse than anyone else on the physical tests. So that was important to understand too. All right. So what does all this mean? Okay, so we found that our group were worried about falling over, but they weren't really at risk of falling over, and their walking and balance was pretty much normal. So why is this? Like, we don't know. Unfortunately, we didn't really delve into the whys in this study, but I think that is something that maybe is a next step to look at, is why are people worried about falling over? Are they just worried, or is there some other reason why they're not as happy to be roaming about? And the other important thing for us to look at from a research perspective is, can this be improved with exercise? I think the research is a little bit inconclusive in older people about fear of falling and exercise. I think there's a little bit of evidence that says that older people, if they exercise a bit more, can reduce their fear of falling. But I don't think I'm not an expert in falling as a field of physio, but I think that would be interesting to look at in people with cervical dystonia. So if we got them fitter and healthier, would they be less worried about actually having a fall? The other interesting finding we had was that our group showed less physical activity than healthy people who were much older. And this is actually really different from a survey that was done by Alana McCambridge a couple of years ago, where people with dystonia were surveyed, and 88% of them reported that they did moderate to high levels of weekly exercise. So they were reporting themselves as being extremely active, and our group reported themselves as being quite sedentary. So there could be two reasons for this. It could just be the difference in groups. So, you know, our group was a slightly less active group, and Alana's group was really very active. That's possible. Or, you know, in fact, that's probably what is happening there. It's probably the likely answer. It's just the group of people. And if we got a different group of people with cervical dystonia, we might get a different response there. And if she repeated her survey, she might get a different response as well. But that was kind of interesting. And in terms of exercise for cervical or dystonia, that's pretty much the only other study we have. There's not a lot of research on how much exercise people do and what they're doing and why they're not doing any more exercise. So again, that's probably an area that needs a little bit more investigation, because we really don't know which study is showing the true story, and both of them might be showing a story, but the true story hasn't really been teased out properly yet there. The final really important thing we found was that the shoulder movement or upper arm movement was slower in people with dystonia. Now, this has been mentioned in a couple of papers from the past, but no one has really looked into that very deeply as yet. All the papers up until this point have basically just suggested that, oh yeah, that's just a factor of the actual underlying condition, so the brain dysfunction of cervical dystonia. And it does kind of make sense. You know, if you have something that's affecting your neck muscles, obviously your neck muscles connect to your shoulder, and, you know, it's going to impact on how you can move your shoulder. So at the moment, that's kind of the level of understanding we have for that finding. But again, that could be something that could be investigated a bit more, because there may be more to that than meets the eye. And also, that's another thing that physios may be able to help with, because if you have some sort of problem with your shoulder, you know, we could maybe prescribe some exercises to get your shoulder moving a bit better. Okay, so where do we go from here? I think we've decided at the end of this study that because the walking and balance assessments of this group were really quite normal, like very normal, but there's no need to really look at walking and balance anymore in people with mild to moderate cervical dystonia. However, it may still be a problem in people with severe dystonia. So that's something for physios to keep in the back of their mind, that if they have someone with a very severe cervical dystonia, they still may have balance and walking problems, and they may fall over more often than other people. We don't know. But that is something that physios can look at in the clinic and try and help with exercise if that looks like that's a problem. We still need to look into the reasons for why people are worried about falling over when really they're not really at risk of falling over, and their walking and balance appears to be fine. So that's the next area of research, I think, that would be really interesting. And, you know, it is also something that we potentially could improve with, you know, more of these group exercise aerobic classes with people to get them a bit more fitter and healthier, and they may not be so worried about falling over in the future. So therefore, from a physio point of view, these are the things that I've taken out of it, and things that I hope to impart to other physios so that they have a bit of an idea of how to help people with cervical dystonia. So that was the end of the first study. Just a little bit of an outline of where the study is going from here. I'm currently planning a survey. So what I would like to do now is look a little bit more holistically at what other things people are using to help themselves with their cervical dystonia. So I'm planning that at the moment. It'll be out probably early next year. looking at asking people, what other things do you do that helps you? And the idea is to try and get a bit of a broad view of, you know, some brief guidelines together about how, you know, what sort of things we can do to help people with cervical dystonia, and so that we can get those out to clinicians everywhere. And that last piece of the puzzle is a survey of international physiotherapists, which I'll be doing towards the end of next year, which is just trying to get the any experts. I mean, there are not many experts out there, but there are a few. There's probably a handful of researchers across the world looking at exercise, physio and activity for people with cervical dystonia. So I'm hoping to do a survey of those international physios, and with a view again to trying to get together some sort of guidelines. It's a tricky thing as a physio to try and treat a condition that's quite rare, and so we would like to try and get together some helpful information so that physios can have a, you know, if you find yourself with a patient with cervical dystonia in the clinic, you've got a little bit of some knowledge behind you and a bit of guidelines somewhere to start to help people. So that's pretty much the end of the presentation at the moment. I'm sure I'll be back in a year or two to present the guidelines on the next the next step in the study. So that's the end of the presentation for today.
On behalf of the members, I'd just like to thank you, Melanie, for a wonderful presentation during our Dystonia Awareness Month, and also for your dedication to people with dystonia over many years. We wish you well in getting that doctorate.
Yes, thank you.
Thank
you very much.
Thank you very much.